Hello, everyone. Welcome to Ask Your Liver Doctor's educational series. This is our new time, 6 p.m. This is Farah Douglas, President and CEO of the Liver Health Foundation. We are a California-based 501c3 patient advocacy nonprofit foundation. We represent liver patients in California. So we thank you for joining us tonight for this special presentation. Tonight's webinar is about Wilson disease, a rare liver disease that causes excess deposit of copper in liver, kidney, and other organs with severe consequences. We don't hear much about rare liver diseases because, of course, they're rare. So tonight is a great opportunity to hear from our expert hepatologists about this disease. Our expert hepatologists will offer information and will respond to your questions at the roundtable section of this program. Our goal in hosting these free educational webinars is to raise awareness of various forms of liver disease and provide accurate and timely information about treatments, new trends, and new research on curing various forms of liver diseases. We thank our physicians, medical centers, liver patients, and pharmaceutical companies for their support of our efforts. Now, disclaimer. Please remember, information given by our expert is not a substitute for advice given by your own physician or healthcare provider. We do not endorse doctors, hospitals, medical groups, or treatments. All right. Orphalon Pharmaceuticals is the exclusive sponsors of tonight's program. We thank Orphalon for their support of our efforts. It is my pleasure to introduce Mr. Mason Lay, Key Account Manager, Southern California region at Orphalon. Mason, would you like to tell us more about Orphalon?
Yeah, hi everyone. My name is Mason Lay, and I am a key account manager with Orphalon. And for those of you who aren't familiar with Orphalon, we are a company focused on helping patients with rare diseases, specifically patients with Wilson disease. When it comes to rare diseases, as you all can probably imagine, even one therapy can change the course of someone's life. So while the number of patients may be small, our mission becomes even that much more important. And that's really the heart of Orphalon, making sure patients with rare diseases are never overlooked. In regards to Wilson disease, Orphalon developed Cuvure, which is medication specifically designed to help remove excess copper throughout the body, and as a result, helps to improve patient outcomes. With that said, I would like to introduce Corey Fromm. Corey is one of our medical science liaisons at Orphalon and is here to provide an overview of Cuvure. So, Corey, take it away.
Thanks, Mason. I'll just share my screen here real quick. All right. You see that okay? All
Yes,
right, so
we
I'm
can
going
see
to
it.
talk about our new drug for Wilson disease, Cuvure. So it's trientine tetrahydrochloride. Many of you are already familiar with trientine. It's an older drug, came about in the 1960s as trientine hydrochloride or dihydrochloride, brand name Cyprine. What we have is this new formulation of trientine. So Cuvure, trientine tetrahydrochloride, or we also call it trientine 4-HCl. It's been on the market in Europe since 2017. It got US FDA approval in 2022 and came to the market here in 23. The indication for Cuvure is slightly different from generic trientine, so it's indicated for the treatment of adult patients with stable Wilson disease who are decoppered intolerant to penicillamine. In a study with Cuvure, we showed that it has a dual mechanism of action, meaning it works in two ways. So it's a copper chelator. It binds copper in the body and induces renal excretion, so you pee it out. And it also works by inhibiting GI absorption of copper. It blocks it by about 50%. Cuvure is the first drug for Wilson disease in about 20 to 30 years. So the last FDA-approved medication for Wilson disease was zinc acetate in 1997. So this is how Cuvure is supplied. It comes in this handy blister package. It's tablets versus capsules. The tablets are scored. So if you're a patient, you have issues with swallowing the large capsules, you can cut the tablets in half. Or for physicians, if you want to do a half dose, you can do it that way. The tablets are 300 milligrams, 150 milligrams a base. The biggest differentiating factor with Couvreur versus the past formulations of Trientine is that it doesn't have to be refrigerated. So you can take this with you on the go, put it in your pocket, put it in your purse. It doesn't have to be stored in a cooler pack. So that really helps with compliance and ease. Couvreur dosing, the range is 1 to 10 tablets a day. Most patients take about 4 to 5 tablets a day in 2 divided doses. So that's how we studied it. So if you're taking 4 tablets a day, 2 in the morning, 2 in the evening. Like all medications for Wilson disease, it has to be taken on an empty stomach, at least 1 hour before meals and 2 hours after meals, and an hour apart from other medications. The main benefit, like I stated, is that it's stored at room temperature. And then if you're converting from other medications used for Wilson disease, that'll be talked about today, like generic Trientine, penicillamine, or zinc, we have a conversion calculator on our website. For Trientine, it's not an exact conversion. The base amounts are different. We can help with that. With penicillamine, we have data from our phase 3 study, and zinc as well. We can also help with conversions. So important safety information. So I have to go through this as mandatory. So potential worsening of clinical symptoms at initiation of therapy. This can include neurologic deteriorations. Once you start mobilizing the copper stores early on, it can cause this transient neurological deterioration, usually with initiation of therapy, so not always seen with Couvreur. If it does occur, adjust the dose or discontinue therapy. For monitoring Couvreur, you can use the NCC test. This is our new free copper blood test that we used in our phase 3 study, and we've been rolling out in a pilot, or the more conventionally used 24-hour urinary copper excretion test. Copper and iron deficiency can occur, so make sure you monitor. Hypersensitivity reactions characterized by a rash were reported in our phase 3 study in 3 patients. 1 patient had to stop the drug due to rash. Other common adverse reactions include abdominal pain, change of bowel habits, alopecia, and mood swings. So my last slide here before we get on with the program is our Navigator program, and this is our patient support program that we offer through Orphalon at no cost. So we have a dedicated care coordinator through our partner pharmacy, PantherRx. So this is someone who's going to make sure you can get on Couvreur, that you stay adherent, you're able to get refills. We've published recent abstracts showing that using PantherRx, we have an adherence rate greater than 90% with Couvreur. We also have a copay program. So for eligible commercial patients, it'd be a $0 copay. We have a quick start program so patients can get started on the drug right away while insurance is being processed. And then lastly, for patients where insurance doesn't cover it, it goes through the appeal process. We have a patient assistance program. So if you want to learn more about our drug, you can go to couvreur.com. Or if you want to learn more about our company and what we're working on and what's to come, you can go to orphalon.com. So thank you, and I'll turn it back to you, Farah, for the program.
Okay, now it is, thank you again, Orphalon, as I mentioned. It is now my pleasure to introduce a great friend of the Liver Health Foundation, Dr. Jeffrey Kahn. Dr. Kahn is a professor of clinical medicine and the medical director, liver transplant program at Keck School of Medicine, USC. Dr. Kahn has been helping, of course, Liver Health Foundation, since 2014, 2015, Dr. Kahn. It's been a long time. And Dr. Kahn received his fellowship training in gastroenterology and transplant hepatology from the Keck School of Medicine and Cedars-Sinai Medical Center in Los Angeles. He is board certified in internal medicine and gastroenterology and, of course, transplant hepatology. Dr. Kahn's primary research interests are in transplantation, hepatocellular carcinoma, which is the liver cancer, and viral hepatitis. He has written and co-authored several abstracts and peer-reviewed articles on various topics, such as chronic hepatitis C and liver transplantation. He's also a distinguished lecturer. Dr. Kahn is a member of the Liver Health Foundation's Medical Advisory Council. We were privileged to acknowledge Dr. Kahn and USC liver transplant program for their wonderful work and exceptional service to our community by offering the award of excellence in liver care to them. Dr. Khan, as usual, you are wonderful and we thank you so much and we are ready for your presentation.
Yeah, thank you. Thank you very much for the invite. Let me share my screen. Can everybody see this?
Yes.
You can see my screen?
Yes.
Okay, awesome. Yeah. So Farah, I want to commend you for not saying Wilson's disease.
Oh,
I have a picture of Dr. Wilson, I think, on the next slide. So Dr. Wilson neither had Wilson disease nor did he own it. And I think the new nomenclature is actually Wilson disease. So I commend you on that because that's not very common. So,
thank you.
you know, Wilson disease is sort of a passion of mine and an interest of mine. So I'm really happy to be back to talk to, you know, patients and other providers and whoever else is on here a little bit about Wilson disease. So I want to go through the timeline. So, you know, this disease has been known since the 1800s. And really, Dr. Wilson, and this is his picture, was a neurologist who had a thesis in 1911. This is the title of his thesis, where he sort of put the idea of sort of brain accumulation of something, wasn't clear what it was, and cirrhosis together. And that's sort of where the whole sort of concept really started. And you can see, you know, the whole idea of copper, you know, was actually known very early. And the idea of sort of removing copper was very early as well. Ceruloplasmin was, you know, known back, you know, almost 80 years ago. I know that trientine, you know, was approved not that many years ago, but actually this was actually studied back in the 60s, and penicillamine back in the 50s and 60s. And then we cloned the gene for Wilson disease ATP7B in the 1990s, and now we really know a lot more about it. Interestingly, though, we still have, you know, the treatments really have been pretty similar over the years, with some tweaks and some improvements over the years that we'll talk about. So what is it? It's a rare genetic disease. There's copper accumulation in the body. Affects about 1 in 30,000 people, although, you know, when you talk about the incidence and prevalence of diseases, it's only as good as, that's actually should be 1,000. I'm sorry, 1 in 30,000, not 1 in, I'm not even sure what that number is. But when you talk about the prevalence and incidence, you know, that those numbers are only as good as how often you actually look for these diseases. It's passed from parents to child. If each parent has a copy, then there's a chance that a child will be at risk. And so if each parent has a copy of the genetic defect, then each child will have a 25% chance of actually having the disease. So it's very, very important. There's excess copper that builds up in the liver and other organs, and symptoms usually don't occur until teens or 20s and even beyond. And I treat and have diagnosed patients in their 50s and 60s with Wilson disease. So it's not just a disease of early sort of, you know, adolescence and 20s and 30s. So we need to think about it in patients even after that period of time. So really, what is it? It's really, again, a disease of excess copper absorption in the liver, in the body, and then it deposits in various organs. And usually, most copper actually ends up going out into the stool. But unfortunately, in Wilson disease, the genetic defect doesn't allow the copper to get into the bile and then into the stool. So it purely depends on copper excretion, and that's not very efficient unless we do something to help that along, which is the chelators that we talked about, that we'll talk about a little bit later. So basically, over time, copper can accumulate in tissues, various tissues, which we'll talk about. So right here, so in the brain, an area called the basal ganglion, which is the area that's affected in people with Parkinson's disease. So people with Wilson can present with movement disorders, difficulty speaking, difficulty swallowing, have tremors, and, you know, for, you know, all intents and purposes, somebody might think they actually have Parkinson's disease, but it's actually Wilson disease. They can have heart issues. They could have anemia due to accumulation of copper in the blood cells that actually causes the blood cells to get destroyed. It can cause bone loss, can cause joint problems like osteoarthritis. And in the case of the liver, which is, one of the more serious aspects, can cause serious damage to the liver, which causes eventually cirrhosis of the liver or even liver failure. And it's really a multi-systemic disease. And if the good thing about the disease, if we catch it early, it's 100% treatable and people will never have a problem. If you wait too long, you can have irreversible problems. So these are all the various ways that Wilson disease can present. A lot of people just present with abnormal liver tests. Some people present with fatty liver on an ultrasound, which is probably the most common way that I see patients referred to me, and then I diagnose them with Wilson disease, just an ultrasound in maybe somebody in their 20s that shows some degree of fatty liver. In some patients, especially younger females, they can present with acute liver injury that's very severe that often requires liver transplantation. Some people present with something that looks like something called autoimmune hepatitis, which looks like an immune response against the liver, which is actually due to copper accumulation. Some people just come in with the neurologic problems, such as dysarthria, which is difficulty speaking, tremors, drooling, difficulty sleeping, insomnia, and also psychiatric disorders such as depression, bipolar disorder, difficulty learning. And I would say that anybody who's a child, adolescent, in their 20s or even a little bit older, who presents, with issues of learning disorders, depression, and some of these sort of neuropsychiatric disorders should be screened for Wilson disease. And a lot of times the disease is actually diagnosed or thought about by neurologists before they come to see the hepatologist. And then some of you, I'm not sure how many patients are on here, they can develop Kaiser-Fleischer rings, which is accumulation of copper in the eye with a certain pattern that's usually noted by the ophthalmologist, special kind of cataracts called sunflower cataracts, kidney issues because of accumulation of copper in the kidney that causes some problems, again, some heart problems as well. And in a female who's had repeated miscarriages, we often think about Wilson disease because many liver diseases themselves can cause problems with fertility and ability to carry on a pregnancy. These are things that I really, sort of think about when I talk to patients or when I talk to, people in general about Wilson. Really a change in school performance, depression, personality, mood changes. That's about a third of cases. And oftentimes these people have no obvious liver issues because this can occur at a sort of a younger age than we sometimes see the liver issues. Again, eventually these people will always develop liver problems at some point. We want to kind of reverse things before they're irreversible. If the neurologic injury goes on too long, it may not be reversible. And that's very sad because, again, these changes are completely preventable if we catch patients or people early. So I think the neurologic issues are really, really important. I already just talked about those. The genetics we talked about. So if each parent is a carrier for the gene, then there's a 25% chance that any given child will have it. So it doesn't mean that if you have 4 children, one will have it, but every child that's born will have a 25% chance of having it. And that's not a reason for people not to have children, but children need to be screened so that way they can be treated. Because again, if it's treated, appropriately, there's never going to be a problem. I'm not going to go through this too much, but there's an algorithm for determining whether or not, somebody has, definite Wilson disease. And it's things like looking for these Kaiser-Fleischer rings or this accumulation of copper that's in the eye, whether they're present or if they're not present. And then looking at the ceruloplasmin, which is a protein that is made in the liver that helps distribute copper into the bile so it's excreted. And if that level of that protein is very low, then we do things like liver biopsies, look for the amount of copper in the liver. We do sometimes genetic testing, and then we can determine whether or not, it's likely that somebody has Wilson disease. I will mention that the genetic test, which is that ATP7B gene, a patient would have to get 1 copy from each parent, and there are probably 500, 600, 700 mutations that we know about or changes in the DNA structure that we can test for. But some people have a mutation that we can't test for. So having a negative genetic test does not mean somebody does not have Wilson disease. So we like to check for the genetics really as somewhat of a confirmatory test, but also to help determine sort of how to screen, first degree relatives, because if we know the genetics of the person with Wilson disease, then we can screen their siblings, which are probably the most important people to screen. I'll also mention there are other reasons for copper excess that aren't Wilson disease. So it's very important to make sure that you're screening patients and then you're actually diagnosing them properly, because if you take out too much copper in somebody where you shouldn't, that can cause other problems. In terms of standard testing is the ceruloplasmin, which is that protein that I talked about, a urine copper collection. So we collect a 24-hour urine copper. I want to mention I send patients to the lab to get their copper checked in the urine, and we give them a bucket to actually collect the urine for 24 hours. The first urination in the morning is made in the toilet, and then after that, it's collected for 24 hours, and then the next morning, the last collection is actually in the bucket. And it's important to make sure that we check for copper and also for a test called creatinine, which is a kidney test, and it just tells us whether it's an adequate collection. I have a lot of patients that I send to the lab for urine copper, and they ask them to have two different buckets, one for the copper, one for the creatinine. And the reason for the creatinine is to make sure that the copper bucket collection is an adequate collection. So if somebody says you need two different buckets, it's the wrong test. We do the genetic testing called ATP7B. We check liver copper content, where we actually do a biopsy, and we send off the biopsy specimen for the actual amount of copper in the biopsy. We do eye exams for these Kaiser-Fleischer rings, which is right here around the iris of the eye. And it's a ring that's very hard to see, especially in people with dark eyes, but ophthalmologists are very adept at looking for these. And then something called sunflower cataracts, which are actually right here, and it kind of looks like a cataract, although it's again caused by copper accumulation. I must say, I'm not sure I've really actually seen sunflower cataracts. I had a picture which I think disappeared when I changed the background of the MRI in the brain, but it actually can show copper accumulation in the area called the basal ganglia, and again, which is an area that we see accumulation of other problems in people with Parkinson's disease. And that could be an early clue. So anybody that I have with Wilson disease, I send for an MRI just to see if there's some changes in the brain. In terms of the treatment, the standard treatment is D-penicillamine, or at least the historically common treatment. This is a drug that's taken usually several times a day, sometimes 3 times a day, sometimes 2 times a day, depending on the wish of the provider and also the patient. All the drugs have to be taken on an empty stomach. This particular drug requires a drug called vitamin B6, or a vitamin called vitamin B6 to be taken, because the drug actually depletes vitamin B6, which causes blood problems. So you have to take that. I must say this drug can cause side effects like fever and rash, sometimes kidney issues. So I would say the majority of patients nowadays being started on treatment are probably not started on D-penicillamine because of side effects. But sometimes insurers won't allow other treatments unless we try the D-penicillamine first. So it's very reasonable to try it. If somebody doesn't have side effects, then they're fine from it. Trientine hydrochloride, which is the brand name historically was Cyprine, is another kind of a chelator, meaning that it sort of binds the copper in the blood and then allows it to get into the urine. And again, it has to be taken on an empty stomach. The problem with this drug, they're capsules, but it has to be refrigerated. And that's a problem because a lot of my patients are actually young, they're college students, they're active, they're doing normal things that young people do. And it's not so easy to take a drug 3 times a day that has to be refrigerated and they have to carry around a pack on ice. A few years ago, the FDA approved Couvreur, which is another kind of a trientine, which again has to be taken on an empty stomach. It's approved for patients who have been on D-penicillamine before. This is a drug that does not have to be refrigerated, doesn't have the same side effects as D-penicillamine, and I find actually very easy to use and very easy for patients. And I've converted many patients to it, but again, that's a personal choice for patients and a decision between them and their provider. So I'm not here to advocate for any particular treatment, but it's something I've used. Zinc acetate or Galzin is a zinc agent. It's very interesting. So zinc is very similar to copper in terms of its structure. So what zinc does is it gets absorbed into the intestinal cells, and it tricks the intestinal cells into thinking it's copper, induces an enzyme that then binds copper. The copper then can't get absorbed, so it gets excreted into the stool. So it works very differently. It actually decreases iron or copper absorption. It's taken generally 3 times a day, although in some cases less, depending on the patient and the response. Again, an empty stomach, but it's quite easy to take, and it actually is usually a good drug for people who have been on other drugs for a while that have sort of unloaded the copper. In some cases, it's a primary treatment, depending on the patient. It's very safe. The major problem is some GI upset, but I don't think I've had many patients, or I'm not trying to think of patients that actually weren't able to take it. Does it require refrigeration? In some cases, the insurance doesn't cover it, although I understand that that seems to be less of an issue these days. And there are other zinc compounds that are over the counter that are available, such as zinc sulfate and zinc gluconate. But I don't think those are FDA approved for this purpose, but they can be effective. If somebody can't afford the drug and can't get it, it's better to be on something that has been shown to be effective. So sort of leave it at that. But apparently, the company that markets Galzin has a program that makes it easier for, number one, pharmacies to have this drug, and number two, for patients to obtain it through their insurance. I think diet is the biggest issue with my patients. A lot of things that people like to eat are actually high in copper. So chocolate, liver. I don't know that many people like liver that much. I have a lot of patients with Wilson who are vegetarians and love mushrooms, and mushrooms are high in copper. Nuts are often sort of protein substitutes for vegetarians, and they're kind of off limits, at least in significant quantities. And then shellfish. I actually have several patients that had gone on sort of cruises, ate a lot of shellfish, and came back with their copper tests sort of off the chart. So it's really important. So it's really important for patients with Wilson to actually meet with dietitians, have a good dietary plan. It's important to not use copper piping. I actually I went on a vacation last year to France, and I went to the artist Monet's house. And in Monet's house, in the area where he had lived, in his kitchen, he had an entire wall of copper pans and pots. And I had sent an email with a picture to my colleagues, and I said that I hope nobody in his family had Wilson disease, because you want to avoid anything with copper in terms of cooking, because it could actually leach out into the food. So very, very important. So I have everybody also make sure they're not taking any supplements with copper, and just make sure that they meet with a dietitian, and they're just careful. It doesn't mean somebody can never have chocolate or any of these things. It's just really in moderation. And we're monitoring lab tests to make sure that copper levels are okay. So if somebody's copper levels suddenly go up, I give them a call and say, hey, what's going on? And sometimes it's like I had some dietary indiscretion, which happens, and it's okay. We're all human. So in terms of monitoring, for office visits, again, many of my patients are young patients. They're busy. They're in college, many of them. I've set up, visits like telehealth visits on weekends. Sometimes when I've been on vacation, even out of the country, just to make it convenient, because it's really important to follow up and for them to maintain that rapport with the physicians and take their medications. I check blood chemistries. I check a blood count, because a blood count, if somebody's copper deficient, can actually go down. The serum copper is a little bit difficult. There is, I think it was mentioned by the Orphalon person that spoke earlier, Mason, that there is a study looking at a new type of a copper test for the blood that seems to be more accurate. Historically, serum copper tests are really not very accurate and not all that useful, and many people don't check them. Ceruloplasmin actually, interestingly, can be helpful in some patients, and you can sort of calculate the amount of true copper in the blood based upon measuring a serum copper in the ceruloplasmin. And if a patient notices that their ceruloplasmin is dropping, it could mean that they're becoming copper depleted. And for me, it's sort of a clue that I need to sort of reassess medications and things. And then that 24-hour urine copper test is really important. And I think for all of my patients, I would want to check them no less often than every 3 or 4 months, sometimes more frequently. And I suppose if they're many years out from diagnosis and steady treatment, maybe a little bit less frequently. In terms of the first degree relatives for patients, we talked about checking the sort of ATP7B, which is that genetic test. I think that, based upon that, we can make decisions about, what we need to do, especially if a patient is, or a family member is actually symptomatic versus not having symptoms. And, I think the most important thing is probably to alert the patient's first degree relatives that they need to talk to their own physicians, providers about this. And I actually give this sort of little list here to them, because obviously I'm not taking care of the donor, I'm not taking care of the family member and say this is something that somebody should look into. If there's any question, probably would be helpful for that family member to actually maybe see a hepatologist. Again, it's important to screen people, because there are a lot of people without symptoms, and we can catch them without symptoms. And if we catch them without symptoms, they'll be fine. If we catch them with early symptoms, they'll be fine, as long as we start treating the patients with appropriate medication. So I think that's it for my presentation. I really wanted to leave a lot of time out for questions. So I'm going to stop my share and then see if Sarah wants to come back on.
Yes. Thank you so much, Dr. Khan. This was really fantastic, and I absolutely would love to hear more about the diet part that you talked about, especially mushrooms, because we hear mushrooms have so many good qualities that we should include in all of our food. And of course, chocolate lovers in all of us. We'd love to hear more. So now, before we start our roundtable discussion, I would like to introduce Dr. Saro Kemichian, MD, FAA, SLD. Dr. Kemichian is a board-certified transplant hepatologist and assistant professor at the Keck School of Medicine of USC. He earned his medical degree from the Keck School of Medicine of USC and completed his residency in internal medicine and fellowship in gastroenterology at the LAC plus USC Medical Center. He further specialized in transplant hepatology at Keck School of Medicine. He is affiliated, of course, with Keck Hospital of USC and USC Verdugo Health Hospital, where he provides comprehensive care for patients with liver diseases, including chronic liver disease, cirrhosis, hepatitis B and C, liver transplantation, and hepatocellular carcinoma. His research focuses on complication of chronic liver disease, liver transplant outcomes, and global public health initiatives, including his role on the AASLD Global Outreach and Engagement Committee since 2022. Dr. Kemichian is recognized for his expertise in treating non-alcoholic fatty liver disease, known as NAFL, cirrhosis, and alcohol-related liver damage, with a higher volume of cases than similar providers in the region. He has been honored as a Fulbright Scholar in 2023 and continues to contribute to global liver health through teaching and research in Armenia. He speaks English and Arabic and offers telehealth appointments. His practice is located at 1520 San Pablo Street, Suite 1000, Los Angeles, and he accepts multiple insurance claims. Okay, so now, thank you, Dr. Kemichian. This is your first visit with us at our webinars, and we appreciate your being here with us. Thank you. And with that, let's start on the questions. Let me ask a quick questions and then another question before we get to the rest of them that I had sent to you. One of the doctors who is listening and watching the program is asking if Orphalan's medication has been approved for pediatric. Do we know, Dr. Khan, Dr. Kamakian?
I think it's only approved for adults, but I would defer because I'm not a
Yeah.
pediatrician, so I don't want to make that comment.
I also saw that
I
package insert that was for adults, but maybe Corey can comment for
Yeah, I
the.
can answer that. So our product is approved for pediatric patients in Europe under the brand name Cuprior. We are obligated and committed to getting a pediatric indication here in the US. We just don't have public information out in the public domain at this time on a timeline. We should this year have more information. When that happens, we can let you all know. But something we are working towards. So, yep. Thank you.
Thank you.
that's good.
Okay, now another of our audience, Christina, is asking, can puberty affect liver enzymes and other liver marks for children who are living with Wilson disease?
Puberty. I mean, sometimes I think hormonal changes can certainly affect liver and, of course, Wilson disease as well. So hormones certainly do make a difference. So hormonal changes.
I'll say one of the things that can actually raise copper levels in general is increased estrogen. Again, we're not pediatricians, but I wouldn't be surprised in females that are going through puberty and estrogen surges and things like that there may be effects. But again, I'm not a pediatrician, so it's kind of hard for me to discuss. But I also say in terms of males and testosterone can affect the liver in different ways. But again, I think anytime, you're dealing with sort of changes in phases of life, it's important to sort of look at somebody with liver disease and see if there are any changes, such as, again, I think puberty, I think, the pregnancy, I think, going through menopause, and then various stages at older ages, because things change in general and liver disease changes in general. I think it's always important to sort of look at a liver disease at different phases a little bit differently and reassess what are we doing in terms of medications and treatments.
Thank you. Okay, another question from Eva. She asked, my 15-year-old son has advanced neuro-only Wilson disease that has gotten progressively worse over 3 months of zinc-only therapy. For neuro-Wilson patients, do you recommend, and Dr. Khan, you mentioned that several times, and it's hard for me to pronounce, but I'm going to try, penicillium, is that correct? Or
penicillamine,
and tritonine,
Trientine.
right? As a first line of treatment. And which one of those has less side effect?
I would say that when you're dealing with neurologic effects of Wilson, again, a lot of younger patients have purely neurologic effects. Some medications that we use in certain instances can actually make it worse. So it's very personalized. And I don't think it would be proper for either of us to comment on a particular treatment, and which is better. But what I would say is in, Wilson disease centers, right? It's very important, especially for any Wilson disease center, to have neurologists who are experiencing Wilson disease and movement disorders and hepatologists managing patients. So what I would say is, it's important to make sure that there's both a hepatologist and a movement disorder Wilson disease expert neurologist involved with the decision making, because there are a lot of different options, and some medications might make one thing better and might make something else worse. But again, it's really hard. I don't think it would be good for us to comment on a particular patient and the best treatment, because everybody's a little bit different. But I would just make sure that people are seeking out treatment with experts in the area to deal with the various aspects of Wilson disease.
Thank you. Dr. Kamakian, do you want to add anything to that?
Yeah, I mean, I agree. I mean, there is obviously ways to monitor and make sure the treatments are adequate in terms of any particular patient. So in a sense, is the copper being removed from from the body appropriately. There are obviously ways to do it, and I agree that the patient should be plugged in with an expert in Wilson disease. And as Dr. Khan mentioned, sometimes patients actually their first encounter is with a neurologist. So it's important to have a neurologist for sure involved in the care as well.
Thank you. Another question, this one is from Leslie, and she's asking, how should clinician manage patients with suggestive features of Wilson disease, such as soruloplasmin, liver fibrosis, or neuropsychiatric symptoms, but with only one detected ATP7B variant? Should these carriers still undergo periodic copper monitoring, or if so, how often should they be monitored?
So I think it's the carrier patients or carrier individuals, I should say, don't have many phenotypic sort of features of Wilson disease. They may have some some not significant, but low amounts of ceruloplasmin and elevated copper. But it's my understanding that they don't typically manifest with too many physical features of Wilson disease. I don't know if Jeff wants to add to that.
So in this case, I heard that the patient has fibrosis and neurologic symptoms thought to be from Wilson disease. Because again, there are a lot of mutations and we don't know all of them. And so somebody could have, one mutation. So basically, there's different types. There's something called cis mutation and transmutation, which sounds kind of wonky. Cis mutation means that there are two different mutations, or the mutations on from the same parent. The trans means you have mutations from both parents. So it can be sometimes very hard to tell, number one, are these mutations from both parents? But number two, there are many mutations we don't know about or changes we don't know about. So there's no requirement for a genetic test for Wilson disease. It can be very helpful and it could be diagnostic in some cases, but it doesn't necessarily exclude Wilson disease. And so what I would say is just seeing a really experienced Wilson expert to look at all the other aspects. How much urine is in the copper? How much copper is in the urine? How much copper is in the bloodstream? Have they had their brain evaluated with like MRI and the eyes evaluated and seen all the experts? I would say, it really needs a center where people are really experienced, because again, if there are subtle features of Wilson disease and it's not treated, that could be quite serious. So it's, we're learning more and more about mutations as we go along. So it's really, important. So one copy, even no copies, doesn't exclude Wilson disease. It makes it maybe less likely. But I have patients that have one copy or no copies who meet all the other criteria for Wilson disease and get treated. That said, there are also people out there that get treated that don't have Wilson disease, and we base it on certain tests, like a low ceruloplasmin with nothing else. And that by itself isn't enough to diagnose it. So again, it's very challenging. And I would just say, make sure, I always encourage my patients, if they have, questions, and about diagnosis and things, to seek out other opinions, because sometimes having another set of eyes could be helpful, but just making sure that people are being seen by experts in the area. Because to me, this is the most challenging liver disease, because there are many subtleties. It's a lifelong treatment, a commitment to, compliance with medications, and things are evolving and the science is evolving. I think eventually we'll have gene therapy, and we probably won't even need any treatments for Wilson disease other than gene therapy.
Are these tests very expensive? Because I've received a few questions regarding how in other countries that are not as rich as the United States, can these tests be done? And also, is this test something that lower income family members in America can afford doing them? Are they very expensive? What's the situation there?
Well, if people don't have insurance, the genetic test is expensive, because I've actually I've had patients that we wanted to do testing and the insurance wouldn't cover it. Different scenarios where I wanted to test them. But anyway, it's expensive. The other testing, they're pretty standard. I don't know what the cost is. But I would say certainly if people live in Los Angeles County, they can often get plugged in with the liver clinics at the various county hospitals. LAG MC Medical Center, we have a liver clinic there where we have people with Wilson disease that get treatment, they get all the testing. So if people don't have the resources for testing and for medications, at least in LA County, many other places, there are resources for it. I don't know the actual cost for these things. But the testing that we do, except for the genetic testing, is pretty standard, nothing really fancy. I mean, these are tests, the ceruloplasmin has been around, testing has been around for many, many years, as are the other tests. So I don't know the cost. So
I mean, I
maybe
agree. I
Sarah
think
knows.
the genetic testing is definitely something that's expensive, and I have been denied that as well by the insurance companies. And I don't know if anyone can, well, not anyone, but I'm not sure if it's too affordable. But the others are like typical blood tests that you want to do. And so I don't know the cost either, but somewhere like a county hospital can be very affordable.
So when they take blood tests and they look at your kidney panel and your liver panel, if somebody has Wilson disease, it will show in that blood because of the copper.
Not necessarily. I mean, it depends on what you're looking for and what kind of blood test you've sent for analysis, but it's typically not in the routine armamentarium unless a hepatologist is seeing the patient and there are liver enzyme abnormalities, which we always sort of screen for Wilson disease as well to make sure that that's not sort of there because, as Dr. Khan mentioned, it could be very, very subtle. I think I've seen a patient where the diagnosis was autoimmune hepatitis, but then they weren't responding to the treatment, and so further workup then showed possible Wilson disease. So it's not always that routine testing shows that, and I think having that curiosity of perhaps looking into it a bit further would be important.
Thank you. Question from one of our physicians who's watching the program is, do you recommend and how can we put Wilson disease on newborn screen?
I don't know if, I mean, I think a policy decision by either the states or yeah, mainly from the states. It's checking ceruloplasmin may not be that difficult, but I'm not sure if genetic testing would be feasible. And I don't even know if ceruloplasmin by itself would be a good screening test if there is really suspicion for Wilson. I don't know if Jeff, you have more comment on that.
I think people are rarely having issues before the age of 5 or 6.
That too, yeah.
But I will say there are more and more tests that are done on newborns, and I think we're probably getting to a point where we're going to be doing just sort of a whole genetic panel and sort of looking for screening for tests. Again, having negative tests doesn't mean somebody doesn't have Wilson. I think the major, it's not a very common disease, and I don't know if it's really, it would be considered quote cost effective. But if you're running a whole genome on patients for genetic issues, it'd be very easy to sort of run that along with other things. I will say, it's important to make sure that parents, that they don't have Wilson or there's no Wilson in the family, maybe doing better screening of parents beforehand just to make sure. Because again, 2 parents can have a copy of the gene, not have any issues, and then passed on to a child. So, again, I don't know, but I think we're coming to a time because I was actually looking at, I have a cousin who has a son, and he went for this whole battery of genetic tests that I didn't even know kids were being tested for when they're born. And they found all sorts of interesting things. but they weren't really sure. My cousin is a physician, and she wasn't even sure what to make of all these things. So I think, in some cases, if you're screening like little newborns for things, and you're not sure what to do with those results, you kind of scare people a little bit. So I think you have to be a little bit careful and mindful. But that would probably take an act of like pediatrics organizations and the federal government, to talk about how to sort of mandate that. So, but it'd be very easy to screen the genes. But again, you might miss something. I will say, if you're screening a sort of average risk person with a genetic test and it comes back negative, the what we call negative predictive value of having no copies of the gene or no more than one copy would pretty much exclude Wilson disease because it's such a rare disease. So if you screen negative for the genetics, you probably don't have it. But I don't know that that's coming anytime soon.
Some questions on chat here. So Elisa is asking, I have Wilson disease. When can I test my 17-year-old daughter?
Sarah?
Yeah, I mean, I don't think there's age sort of restriction there. By 17 already, we should definitely start to see. And so I think screening at that age would be appropriate by some of the testing that Dr. Khan mentioned.
I mean, I always talk to my patients about their, children and, and siblings and things, and just make sure that their physicians know that, that this first degree relative has Wilson. And then, making sure that they're plugged in to get the testing based on the guidance. And again, based on, I had a thing that I put up, like a flow slide, I think it was my last slide, showing sort of how to sort of test and when to test. I think a 17-year-old person should be tested because if they have Wilson, there should be some indication and ways to test to either exclude or include having Wilson. Again, it would be very treatable. So I think it's very important to be checked at that age.
Another question from Emma. She says, I have two sons with Wilson disease, 16 and 14 years old. My oldest presented with acute liver failure. The younger is asymptomatic. What is the recommendation follow-up regime with our specialists? What are currently averaging 3 to 6 months for our oldest and 6 to 12 months for our younger ones to visit their doctors?
So the older person had
Older has
liver failure?
Failure. The second one is not having signs yet.
And did the older child have a liver transplant or no?
She is not mentioning.
Presumably, right?
She's saying that her older is saying 3 to 6 months, seeing the doctor, and the younger one is 6 to 12 every 6 to 12 months, seeing his doctor.
So if it's 3 to 6 months for the older, I'm imagining the patient had a transplant, which would be curative for Wilson disease. Well,
yeah, go ahead, please.
No, and for the younger sibling, if they're asymptomatic now, I think they should still be tested. So essentially, again, let their physician know, even if they're plugged into a transplant center, there's going to be probably a hepatologist there, and they should talk to them to screen the other family members as well.
She is responding on time. She's saying no transplant yet for her older son. I don't understand. Okay. She has acute liver failure.
I would just say that it's important just to make sure that the children are getting, again, we're not pediatricians. I can sort of say what I do for adults, and in my adult patients, I like to get labs, every 3 months at least. And then maybe as time goes on, I have some patients I've been following for 20 years. Sometimes they have lapses in getting their labs, but they've been on meds that are stable, but I still like them to get their labs at least every 3 months. If I make a change in medications, I like to do it earlier, just to make sure that my change, either increasing doses, decreasing doses, or switching to a different medication, is still having the proper effects. So hard to generalize, you know.
Yeah, Emma really has a lot of questions, but she's asking if maybe I could give her information to both of you, and if you doctors feel you want to speak with her, because it seems we are running out of time, and she has
I think, yeah, I think
questions.
we would be happy to, if maybe, Sarah, if you could email us her number,
Yeah,
we'd be happy to talk to her. So,
Okay, so Emma, please send me your email address and your phone number, and I will forward them to Dr. Khan and Dr. Kimichia.
absolutely.
All right, very good. And just for information, Errol is saying that Dr. Han at Seattle Children's has developed a newborn screen for Wilson disease, approved by Washington State to start in 2027 or later, depending on the funding.
a new wet screen, I'm sorry.
Oops.
A new screening test.
Yeah, for newborn.
Oh, for newborns. Yeah.
Yes.
I mean, I think it would be great if that's done. I don't know. So if Washington approved, I mean, Washington is a very progressive state. I used to live in Seattle,
Mhm.
and I think they're very much at the forefront of sort of upfront, preventive care. And I think that would be great. And maybe that could be a model for the country, because again, it's better to
Yeah.
know earlier if somebody has something that can cause problems. You can start treatment earlier and all that. So I applaud them if that's what they're able to do.
Okay, I have a lot more questions, but unfortunately, we are running out of time. So we need to say sorry to everybody else whose questions were not answered. Those who have email addresses that have sent to me, I will go ahead and forward those emails and questions to both Dr. Khan and Dr. Kimichian. And you can, if they want to, they can contact. So with this, we are ending the,
Thank you.
I'm sorry, you wanted to
No,
say
no,
something?
I'm just saying, yes, absolutely. If anyone has any questions, we'd be happy to.
Thank you. So, thank you, Dr. Khan. We so appreciate your kind partnership with us. You have been our friend for so many, many years, and I know I can always count on you when I need help. And thank you, Dr. Kimichian. We hope to work with you more in this year, 2026, and moving forward. It's very nice to meet you.
You too. Thank you for the invitation.
Thank you. Thank you,
Thank you.
Orphanon Thanks. Thank you, Orphanon Pharmaceutical, for your support. We appreciate your partnership. Now, Corey, did you have anything else you wanted to add?
No, just want to thank you, Dr. Kamichian and Dr. Khan, for the great discussion. And once again, if anybody has any questions or wants to learn more about our drug Kuvrior, you can go to kuvrior.com, or if you want to see what we're working on, orphalon.com. So thank you, Farah.
Thank you. Okay, now some advertising for Liver Health Foundation. Liver Health Foundation will host a robust liver health screening, health fair, and Walk for Your Liver Pasadena on April 18, 2026 in the beautiful Victory Park from 8:30 to 12:30 noon. The chair of the event is Dr. Edward Mena, Medical Director of the Pasadena Liver Center and Director of California Liver Research Institute. The non-invasive liver screening is free to all who will register and will be performed by trained medical professionals in private tents. Information and also access to healthcare lists will be available in Spanish, Vietnamese, Chinese, and English. But you must register to participate. Go to our website, liverhealthfoundations.org, or use the QR code you see on the screen. Of course, the event will include our normal walk, breakfast, music, and all the goodies that we always bring to these events. The other program that I want to talk about, which we have never done, is a webinar called Transition of Care. This is on May 14th from 6 to 7 p.m. Pacific time. It's in the same webinar format that we have right now. This is the first time we are hosting a webinar on transition of care. And this webinar will address the issues that families and liver patients face as they step transitioning from pediatric care to adult hospitals and also medical centers. We will also touch on the complicated task parents face when their liver patient children are off to college in another city or even another state. And you know, the worries of parents about medications and not drinking and all that stuff that goes with college life. We will host a few families that have actually lived through this transition and will ask them to share their experiences with our audience, so as a guide for everyone else. And finally, we will host a liver health screening, health fair, and walk for your liver, Orange County, on May 30th at William R. Mason Regional Park. We are excited to be back in Irvine in this wonderful, wonderful park and among people in our liver patients in Irvine. Like Pasadena, all the testing will be done in private setting. They are non-invasive liver testing. The co-chairs of the walks will be from Hoag and from UCI. So we will have the same things that we just talked about. We do the walk and we will have the breakfast and the other goodies that we normally bring to music, for sure. This is a chance to get your liver tested with no charge to you. And they will give you the access to healthcare information with the list of all of our doctors that are working with us and other local physicians, hepatologists. And it's in private. Nobody else will know. It's just between you and the technician that's doing the test and gives the final information to you. So please join us. Liver Health Foundation is on all social media, so please check us out. We announce our programs and everything else on our social media. I want to thank our doctors, our sponsor, Orphalon, and especially our audience. We hope that you received the information you needed. So now, at this point, I want to wish everyone peace, freedom, health, and happiness around the world. Be well, take care of yourself, and we see you next month. Thank you.